I have to talk about probably the boring part, which is treatment options, and Stefano will have the funny part, which is when to treat and which patients. So I will try to go fast and review this issue as clear as possible. Usually I divide treatment options, as you know, in two parts: compensated disease and decompensated disease, because the options vary from patient to patient. Let's start with the compensated one. Some of these have been reviewed already. You know very well that we have PIs that we can use in these patients: Cineprevir, Paritaprevir, Gazoprevir. We have a bunch of NS5A inhibitors, which you know very well. And we know also that we have some polymerase inhibitors, particularly Sofosbuvir as a nucleus inhibitor. So these are the data, the safety and efficacy data in patients with genotype 1 or 4 compensated cirrhosis. You can see that things are quite nice in terms of efficacy, and you also can see that from the first combination to the last one, we are over 90% of success rate in all these patients. See that the last data shown combination of Sofos and Velpatasvir reach 99%. So I will go over this data in detail, and just if you want to ask me something, just tell me. It's easy. SOF-CIME, this data you know very well, real-world data, large cohort of cirrhotics with nearly half of them with a history of previous decompensation. Remember that most of these patients were treated with Opdivo, and the 81% was well reproduced by the OPTIMIST-2 trial, in which these patients, cirrhotic patients, were treated with SOF-CIME and no Riba, and was again 81% response rate. Just a note of a Spanish cohort. The real-world data in Spain were presented last Spanish meeting, and we presented at EASL. These are more than 900 cirrhotic patients, most genotype 1b, and in our hands, the combination gave us a very good SVR of 91%. I'm not sure why it's 10 points higher. One of the things is that most of these patients underwent ribavirin treatment. I don't know if this makes a difference. In Spain, most patients are 1b, but I think that is not so relevant for SOF-CIME, but in any case, the results were very good. Second combination, you know very well, the registration trials for Sof-Ledipasvir plus Riba, or no Riba, depending on the length. 92% is the overall rate of SVR. Remember that the data from the registration trials had also some arms without Riba, and remember that the Sirius French study analyzed in difficult patients who failed triple therapy with Vozetela, how did it work with 12 weeks of Sof-Ledis Riba or 24 weeks of Sof-Ledis. The response were exactly the same with both arms. So again, we have here the proof of concept that Sof-Ledis alone could be used in these patients, which is useful, obviously, because of some of them may have anemia. We know very well the data of the registration studies combining Paritaprevir, Ritonavir, Onbitasvir, Dasabuvir plus Riba. Remember that there were no differences in cirrhotic patients, Turquoise 2 study of 12 and 24 weeks. And the new thing was the Turquoise 3 study, in which a small number of cirrhotic patients, genotype 1b, were treated with the combination 12 weeks but without Riba. Given the fact that all these patients had the SVR, I think a good option also for these patients in compensated disease is the use of this combination for 12 weeks. Grazo-Elbasvir, this is a summary of the trials that have included cirrhotic patients, and was presented by Ira Jacobson at the last American meeting. Good response rates, 96%. Remember, however, that the response rate when we do post-hoc analysis was a little lower in patients with genotype 1a, particularly those who had NS5A baseline RAFs. And the guidelines recommend, the label recommends to add Riba and to extend treatment to 16 weeks in these patients with compensated cirrhosis, genotype 1a, and presence of RAFs. And finally, as I showed you in the first slide, Velpatasvir, excellent results in a number of cirrhotics that is very high. In fact, 121 cirrhotics, and almost all of them achieved SVR12. 72 of 73 genotype 1 achieved SVR12, and all of the remaining patients also achieved this outcome. So I think in compensated disease, we have good drug combinations, very safe, and essentially I would say that these are easy patients now to treat. Genotype 3 is a little bit more different. I think we still are not there, although the results are very good. Remember that the first two bars represent the Boston study that Foster published in Gastro last year. Obviously, we see here that the arm of PEC-ribosofos 12 weeks obtained better results than Sofos-Riba 24 weeks, but again, we have better combinations now, and I think we would only reserve this for very, very few patients. We can discuss this later on. Sofdaclatasvir, both in the registration trial and also in the French cohort study, showed very good results in terms of efficacy when combined with Riba. And finally, the Astral study showed that the Sofos-velpatasvir combination worked very good in these patients with compensated cirrhosis. Let me show you the data that Peter Ferenczi mentioned a few minutes ago. We realized when we were treating patients in our unit that we had a kind of high rate of hepatocellular carcinoma recurrence. Remember that most of the clinical trials and all of the registration trials excluded patients with HCC. So we started to treat patients with HCC on complete remission, all of them patients with compensated disease, BCLC 0 and A. And these patients underwent different types of therapy, including all of the combinations I showed you before. The median time between HCC treatment and DAA initiation was, in this small study, 11 months. Then we also analyzed the median time between the last radiological confirmation of complete response of carcinoma and initiation of antiviral therapy was only 1.7 months. And having this, we had a tumor recurrence rate of 27.6%. So 16 of these 58 very well studied patients had a recurrence of HCC. Median follow-up after DAA, very short, 3.5 months. This is significantly higher than the expected based on previous studies. When I see previous studies, there are several ones, but let me just mention that we analyzed data from the STORM study. The STORM study, if you remember well, was a Lancet study published a few months ago, in which patients with BCLC 0 and A on complete remission were treated either with placebo or sorafenib. Looking at the placebo group, the expected recurrence rate during the first 4 months after HCC treatment was 13.6%, so significantly lower than that. This is just a warning. Obviously, this has to be confirmed by a larger series, but the paper will appear probably tomorrow online in Journal Hepatology. And what we did is we reported this to the Spanish agency, and the Spanish agency reported this yesterday to the European agency, and they will probably start to see if more groups, as Peter was saying, have the same feeling and do a database study to confirm or not our findings. We can discuss this later on. So I have talked about compensated cirrhosis. What about decompensated cirrhosis? Some of the data have been shown here very well. In this setting, we obviously do not have all the armamentarium that I showed you before because PIs are out because of warning signs of decompensation, and we essentially have NS5A inhibitors and then sofosbuvir as a backbone in the treatment. You know this data very well. These are the data from SOLAR-1 that were published a while ago by Charlton and colleagues, and you can see clearly that the response rate in genotype 1 and 4 are very good. The numbers in Chelsea patients are small, and this has been mentioned by Nora in her presentation. Overall, the safety is good, although we expect, obviously, in such patients to have some events that we usually attribute to the natural history of the disease, but we obviously don't have a control group here. In Chelsea, patients are very high. You can see that in the group that was treated by 48 weeks, 24 weeks, nearly half of them had severe adverse events. Overall, as I said, the safety is good, but keep in mind that some cases of severe bradycardia, if combined with amiodarone, a few cases of lactic acidosis, and recently pulmonary hypertension have been reported post-marketing. Again, making a strong point that safety data in child puke more than 12 are not available, are very scarce. Same data, very similar, published by Mans this year. I'm not going to go through again. The profile of safety is very, very close to the SOLAR-1 study, so I'm just skipping this out. This is the study by Foster, which is an analysis of patients with decompensated cirrhosis, child puke equal or more than 7, in the National England Expanded Access Program. You can see the results are very in line with what has been published in clinical trials. In genotype 1, the combination of sofosbuvir was superior to sofosbuvir, 92%, which is a very high rate. In genotype 3, as I stated before, things are good but not so good, and you can see that the combination of sofosbuvir gave a 61% response rate, whereas the sofosbuvir was higher with 73% of response rate. Regarding efficacy, SVR rates are similar than the Ali-1 study if you analyze only child B and child C patients, 82%, so it makes exactly the same overall response as this expanded program data. Finally, as was presented before, we also have data from the safety and efficacy of the combination of sofosbuvir. This is the first study in which arms without riba are assigned in a clinical trial in patients with decompensated disease. And you can see that, as was mentioned here, the results in genotype 1 are very good, 96% in the arm that includes riba, and a little lower, not very much lower, in those arms that do not have riba there. I think for genotype 1, the data are good because if we don't want to use riba because the patient is not tolerant, we have a regimen that, although the numbers are not extremely high, allows you to use a combination without riba with, I would say, very good SVR rates. For genotype 3, as you can see here, we have a problem, and obviously only the arm with riba has a good response rate, although the numbers here, as you can see, are very small, only 14 patients or 13 patients per arm. Overall, if you look at the safety data in this clinical trial, it seems that it's excellent. As expected, only those arms in which riba was part of the regimen have anemia that goes below 10 in a percentage that is around 23%, in the other arms not. And finally, we have also some cases of sepsis and hepatic encephalopathy that are probably part of the natural history of the disease, child B patients, but again, we have to keep an eye on all these things. Sepsis and liver failure were the most common cause of death in this clinical study. And I want to finalize with this slide. Obviously, when we treat patients that are infected with HIV and we use these regimens, we have more problems in the post-transplant setting, but also in the pre-transplant setting, we might have some problems. Some patients are aged, and we have to keep an eye on antiarrhythmics. We have to keep an eye if these patients are on atorvastatin or some other statins, if they have antifungals. So just, I think it's safe to always check before treating these patients if they have any drug that may interact with these regimens. In general, I would say that in cirrhotic patients, the data are very strong in terms of DAAs, and most of these patients can continue with their treatments, which are essentially some diuretics, beta blockers, and sometimes antibiotics. But we have also keep in mind that when treating patients who may decompensate during therapy, we may keep in mind that some of them may have to undergo an endoscopy and they need sedation. We had just last week a patient who was with sofosbuvir and had bleeding, had to be sedated with propofol and opiacids. No interactions at all, but depending on the regimen, you may have more problems with that. So just keep an eye on that, check every time you treat these patients, and overall, I think most of these interactions are a green light, so no problem at all. So to summarize what I told you, I think in patients with genotype 1 and 4, the regimens we have are extremely efficacious. Sofosbuvir plus riba 12 weeks or without riba 24 weeks achieves more than 90% response rate in this population. Sofosbuvir can also be used with excellent SVR rates. And finally, I hope in a few months we will have sofosbuvir available. We have to consider riba in decom patients, but I think the arms in genotype 1 and 4 that did not have riba look good, and I think in patients who, because of anemia or other comorbidities, cannot tolerate riba, I think is a good option. And finally, for genotype 3, I think sofosbuvir is an excellent option when used with riba, and in a few months we will have sofosbuvir, which works better in these patients, but again, in child B, it is clear only with the warning of few numbers, small numbers, that riba makes something there. Remember that in patients who are compensated, 3D or grasoprevir, elbasvir are options in genotype 1B patients. If we treat genotype 1A, then we want to include riba in the regimen, and particularly for Zapati, for graso elbas, we want to, some labels advise to sequence these patients to see if there are NS5A RAFs, and then add driver and extend therapy to 16 weeks in these cases. And I think that's all. I was brief because I think it's more interesting to discuss data when I finish. Thank you very much.